Good to see you.
Thank you. Hi. Nice to meet you. I'm Abby in audiology. Yeah. You gave me all your knowledge.
Okay. Is Ben coming?
No, he's trying to get down. Looked a little frazzled, but
Okay.
Right, yeah. I have a patient at 12:30, so I'll have to sit it out.
Good. Well, good to see you. Talking about.
I
They
know.
never touched this at all. Have we? I'm sure they'll be working on that.
Yeah, Morgan mentioned
There's more to be doing.
Office is at Road Road in South Road. But she picked up she was there yesterday. But she's a good kid. She's in like a and then yesterday she had to elevate the light. He's good. Back in the radio, so he's happy. I don't know. He's rented at 3 to 7. And then he does like pass sales. We'll probably discuss it this weekend.
It's been a while.
Yeah, he's like, we'll just get out and
Took our front boys right out the front. And ripped
started
the wires right out of our house.
he moved for a while, and then he hurt himself, and he stopped. Well, I think he hurt himself somewhere else, and then fixed himself. But yeah.
Farm mill.
Yeah. Yeah, he lives on 22.
Half on the right.
Yep, and he turns.
It's right past that. You go up.
And then you're not. He turns. So we can say hi to an old friend. Working. Oh, yeah, I've worked here since I left. I've been right upstairs with Dr. Lee. In Miami.
We're all together, that's right.
Yeah, the doctor is coming out. I was like, he's a little rough. I'm not sure. Oh, yeah, no, I'm not straight. I'm straight, but I was like, I don't know. So, did you see Morgan?
No, I didn't.
Stop in. You call. Have a following. So, yeah.
People laugh at all my jokes.
Of course. And
Wow.
I'll track something.
You do, you would, Abby. We used to work with Paul. So, you're looking at us like, what else? We went mushroom hunting trips. You got on your own, right? Are you still doing this?
All this.
Oh, yeah.
We'll be
Last couple of them, you could hear how much.
Yeah.
well, this year.
Yeah.
Get a speaker. In that one, and they always say,
It's on now.
and if they like to ask a question here, just try to repeat it because the people that are on the remote site, I can't hear what they say.
Okay. All right. Hey, thanks.
Ready, set, go? Everyone, to this presentation by Paul Albert on as a lead physical therapist, and now I just treat patients. My passion. I treat orthopedic patients, and I also have treated SID patients over the past 5-6 years. This man here has treated patients a lot longer than as far as visual patients as well. To give you a little history of Paul, he grew up in Westbrook, graduated from Boston University in 1974, advanced his degree in 1982, and he opened up Southern Maine Physical Therapy in 1983 in Westbrook. He had a riding business, so he sold it in 2001, and started with MKM, that most of you know. Doing the rehab. He was credentialed in 2002 and had advanced credentialing in 2007. Paul Albert is really the go-to therapist for vestibular disorder in Maine and away. So without further ado, my mentor and friend Paul.
Thank you, Paul, the go-to therapist.
The go-to.
Okay. Thank you for inviting me. I'm really happy to be here. There's a lot of stuff. I put together a little presentation. I didn't know quite what level deep to go into different things, so I'm going to leave a lot to the question and answer part, but I will be covering vestibular stuff and some other stuff. And I've got some studies that we did at our clinic over the years. And so basically, the Balance Center opened in 1999. And it was the kind of the brainchild of Dr. Maxwell, Bill Maxwell, who's retired now. Does it is still, I think. And he was with MKM, Ian Associates, Max Kluger, and Matt Retz at the time. Eventually, in 2011, we got taken over. We became part of Mercy Hospital. Mercy's been actually good to the Balance Center. When I started working, there was an OT. They started in 1999. There was an OT doing 2 half-days a week, maybe seeing 1 or 2 patients a day when she's in. She went on maternity leave in 2001, and I had sold my practice and thought I was going to retire, but I found I spent up way too much money. And so Dr. Maxwell was looking for somebody to come in and fill in for Stephanie while she was on maternity leave. And I came in, I was working a half-day week, and she never came back. She decided she wanted to be a full-time mom, and I stayed on. We now have 2 full-time PTs, and we work full-time, 40-hour weeks. We're out straight. Thank you for all your referrals. Years. So Dr. Hurst now is our lead ENT, who kind of the mentor for Balance Center, and then Dr. Thompson and Dr. Burke all see physicians and Susan. And Kate is our physical therapist that me, and she's great. We have 5 audiologists there. Supposed to be another slide where? Well, let me go back. It's okay. So the incidence of dizziness, I'm sure you always know this. One of the reasons people go to the doctors, people over the age of 65. Second common complaint, 2% of the population experience dizziness. We're always about falls, comorbidity. When somebody has fallen, they're very costly. With vestibular dysfunction, who are symptomatic, had a 12-fold increased risk of falling. And someone with bilateral vestibular loss over the age of 65 is 70% more likely to have falls. This is the slide I was looking for before. So when we first started the Balance Center, we had a model that worked pretty well for a while when we weren't too busy. The therapist and the physician would interview a patient together, then the therapist would take the patient up to the balancer and do a full balance evaluation, which I have a component of here, I'm talking about. And then they have an audiogram, a hearing test typically, and then the patient would meet with the doctor. We would do a lot of results, speak with the doctor and the patient, but see the doctor again. And that was great, but we were booked out 6 months at one point to get a new appointment. So we changed the model, and now most of the time, if we can, we try to get the patient to see the physical therapist first, and we do an evaluation, and triage the patient, decide whether they need to see a doctor. If it's simple, benign positional vertigo, something that we can usually handle pretty well. If it's more complicated than that, we'll get them to see a physician. If there's a history, if the patients say they think they may have lost hearing, I'll usually call the referring physician and get a referring audiogram, have the audiologist take a look so we get enough information. I've got some statistics on how many patients go on to see the physician and coming on. So the new model works pretty good. So if somebody, now there are a lot of patients who really should see a physician first before they see the physical therapist, and if you feel you have a patient who you'd like an ENT consult, we honor that, and we have some time set aside. It might be that if Dr. Hurst usually does those things, and he's booked out probably 6 weeks, and we get a patient in to see him. Just a quick little thing on the vestibular system, just to talk a little bit of it. Get over here. So you get 3 canals. You get, oops, this works good. This is your, I think that's your posterior, no, that's your posterior canal here. Horizontal canal is right over here. This is your anterior canal that way. This is the utricle, which is the organ that the little crystals fall off of. Mainly want to talk about this here, Scarpa's ganglion. So Scarpa's ganglion is part of the 8th cranial nerve, the vestibular nerve. There's one in the superior division, one in the inferior division of the vestibular nerve. And it is constantly firing at a constant spike of about between 50 and 100 spikes per second. And it's always firing information to our brain. And when we're sleeping, that's always firing. So if we roll over in bed, our reflexes kick in so we don't get our legs and arms tangled up and things like that. And when we move our head, we have this thing called the push-pull phenomenon that occurs. So when I turn my head to the right, it's how I turn towards the horizontal canal is stimulated in a way that causes Scarpa's ganglion to increase in frequency and its rate. The center away from the stimulation to the left side, if I'm turning my head to the right, causes the Scarpa's ganglion to be inhibited and it decreases its rate of firing. It's an important reflex to understand, the little mechanism when we're in rehab, is that's why people have problems with head turns and falling when they have vestibular disorders or vestibular hypofunction. But we'll just go on to the next slide. So I'm looking just briefly about these different things that we treat. But positional vertigo is, very common. It's probably the most common thing we see. Vestibular hypofunction, labyrinthitis, neuritis, Maillet-Debarkman, Meniere's, migraine vertigo. We see a lot of migraines with vertigo, cervicogenic dizziness, dysfunction due to age, acoustic neuromas, severe semicircular canal dehiscence, dizziness, chronic subjective dizziness is a big thing now. So neuritis, as you probably all know, it's a viral infection. It's usually caused by the herpes zoster or herpes simplex virus. And usually because of the herpes virus is dormant nerve tissue and causes, shingles and Bell's palsy. It likes to attack the 8th cranial nerve, also the 5th cranial facial nerve, 7th nerve, excuse me. And people usually have like a vestibular crisis. I don't have a pointer here. Let me go back. Labyrinthitis, okay. Usually people have acute onset of vertigo, nausea and vomiting. Can last for 1 to 4 days. Usually lasts about a day, the actual vertigo, and then they're washed out for 3 or 4 days. During the balance, the gait is off. If the virus causes permanent damage to the eighth cranial nerve. People will develop balance problems, gaze stability problems. The difference between iritis and labyrinthitis is just usually if there's a hearing loss, we detect the cochlear part of the cranial nerve. And very instant, spontaneous, 4 to 12 hours, 1 to 4 days to get better. Often people will completely heal up from that once they get rid of the virus. It didn't cause any damage. They have no residual symptoms. The ones that do have residual symptoms come to see us. Disease is often misdiagnosed, but we believe we have a change in the pressure, fluctuating pressure of the endolymphatic fluid in the inner ear. Episodic two-spinning vertigo characteristics are people have sudden onset of vertigo, happens for no reason. Usually they have a loud, low frequency tinnitus. They are having a hearing loss when they're having an attack of vertigo. The hearing decreases in one ear in the affected ear. It's oral fullness. And then usually the attack takes 4 to 10 hours of nausea, vomiting, often hugging the bathroom floor. And recovers. They usually washed out for a day or two, and over time, the more attacks people have, they begin having a progressive lower frequency hearing loss. And I'd like to get an audiogram when someone comes in. If they can come in when they're having an acute vertigo within a day or two, we'd like to get an audiogram done so we can document if there is a low frequency and have them come back a couple of weeks later and see if that's recovered, if that's changed at all. Over time, people progressively get the more attacks they have, people have more irritation done to the vestibular nerve, and they have balance issues. So, get back to the Meniere's disease. Physical therapy is effective with Meniere's if they have a balance problem. So we'll do a full balance evaluation. If we have abnormal balance typing, abnormal gait testing, physical therapy is effective only if we can get the attacks under control. And if that's with the physicians, diazide, lutein diet, that kind of thing. So mind is a big thing. It's what we see. We see a lot of this. Minds are funny animals. Doctors around here like to see patients with migraines. I got a phone call from one of the main neurology ones asking us to stop sending headache patients to them. We've worked out so we have a relationship, and we them with all our migraine patients now. Migraines can act like VPPV. They can act brain. A lot of people have a history of migraines or a family history of migraines, and they begin having balance problems, and you can have attacks of vertigo caused by migraines without a headache. We have the migraines, the ocular migraines, or the aura that precedes. Some people just have ocular migraines without headaches. The role of physical therapy in this group is I usually will suspect migraines, and so usually all my testing is normal, but they're having these horrible attacks of vertigo. And I'll get out. We have a really nice migraine handout that we give to patients. It's done by the doctors at Johns Hopkins. And we have the migraine diet that we talk about. And if anybody wants me to talk more about those things, I'm happy to. And I move them on if they need medication. Again, we want the migraines to be stable. The physicians will help with that. Dr. Hurst, Dr. Burke, and Dr. Thompson help with that. And once the headaches are stable, if they're still having balance issues, if we have abnormal balance testing, we can treat that. Usually people recover. But again, you've got to get the migraine attacks out of control. I had a lady come in this morning. For 3 years, she's been having horrible attacks of vertigo. They come on for no reason. She's sitting perfectly still at the kitchen table, and just all of a sudden the room starts spinning, and she throws herself down on the floor, and she curls up into a fetal position, and she's an anxious person, and so she's really kind of limited her life. And all of her testing today was perfectly normal, what I could get her to do. She was so anxious, I had a hard time getting her to do some of the tests, but hopefully we'll get things under control for her.
So isn't that much of a role for the physical therapy in this case because it's a balance?
Yeah, so I might do a test. We might do something called a motion sensitivity quotient. A lot of people with migraines have motion sickness and positional vertigo. They'll bend over. They say it's vertigo, but it's really not. They don't get any spinning, bending over, looking up. So I'll put them through a test, get a motion quote. We get a score. It's a Paul, did you MQ, motion sensitivity quotient. And so we'll do that, get a baseline, and then get them back in and test them. And there's treatments you want to have them do the provoking symptoms in a way that the symptoms provoke, but they go away fairly quickly. Don't want anybody to have lingering symptoms for more than 5 or 10 minutes. Sometimes you can progress people to. Sometimes you can't do anything. But most of it is either you go to see a physician, the ENT, or a neurologist. The migraine diet can be very, very helpful. Once they figure out their triggers, they control their triggers. Is anybody here familiar with the migraine diet? Or there are typical things that could be triggers for people. There's caffeine, red wine, chocolate, the typical stuff. But then there's bananas can be a very strong main trigger. Citrus, oranges. So several of my patients over the years have been in their 50s and they have high blood pressure. The physician puts them on a diuretic and eat the banana a day to replace potassium, all that. And then 6 months, 8 months later, they begin having dizziness and balance problems. And we have them stop the bananas and the balance problems go away. That happened several times. Mine is caffeine. I won't go into my story with migraines, but I stopped drinking coffee and all the weird little symptoms went away. And they were pretty severe at times. So we diagnose migraine, vertigo using the National Headache Society criteria. They have episodic vertigo, one migraine symptom of headache, photophobia, phonophobia, or aura, and during 2 vertigo attacks, and often other central. Some people complain of numbness in their face or numbness around their mouth, or transient weakness in their legs, or loss of vision. And why often, or continually. Anybody have any more questions about migraine? I can go on forever. Okay. One more thing about migraine. So I had this guy come in one day to see me because he was having a little bit of dizziness. 4 years old, perfect health, just adopted a little baby. And he said, I just spent a little dizzy, I fell off balance, and I tested him, and testing was pretty normal. And 2 years he came back, and he had been falling down, and then came back, and he was obviously very much off balance. And I had my room at that time had windows that opened, and I had Venetian blinds, and if he'd literally have to turn off all the lights and close the blinds, and if the wind would blow and the blinds would flicker a little bit, and you'd see some sunlight come through, he'd fall to the ground. Actually, we had him wearing he lost teeth, he broke kneecap. We had him with walking sticks, a helmet, and knee pads and elbow pads. Sent him down to Boston to be evaluated. We figured this was a migraine thing. The weird thing about him was he drank 6 liters of Mountain Dew every day, and he didn't eat food during the day. He had breakfast, and he was a high-powered kind of guy. And I saw him. I actually called him a year ago. I had seen him for about a year, and his doctors in Boston found propranolol, and he was walking. He was actually working in a state park ranger, and was able to negotiate the uneven ground, and whereas he couldn't walk before. Triptyline and a few other beta blockers and stuff, but so generalized dizziness. Let me get back to this BPPV. So we see it's positional. Most commonly, people have BPPV in the posterior canal. I've got some statistics I'll be bringing up about what we see. You get this too, Paul. When you have somebody come in with straightforward posterior canal BPPV, it's like Yahoo. You schedule them for an hour and 15 minutes for full eval, but you're not going to be out the door in 20 minutes because you've You do an epi on them, and they're fine. But most of the people who come in aren't like that. They're much more complicated. They have, we see a lot of multiple canal BPPV and anterior canal BPPV, which is difficult to treat. So again, this is to help categorize dizziness. I don't know if anybody wants these. We have copies of these slides. If you want to copy the slides, all of these are available. I think Linda has that. I'm going to print out the handouts. So temporal, episodic. So let's go to the top line there. Provoked by motion, auditory, no auditory changes, and we think BPPV, or maybe an uncompensated unilateral vestibular loss, or artery insufficiency, VBI. Episodic, lasting for seconds to a minute, come on spontaneous, no reason. Mild fluctuations, could be migraine, anxiety, or early Meniere's disease. This is Neil Shepard's book. Shepard's at the Mayo Clinic, and he teaches part of the vestibular course that Paul's into. Seconds to 24 hours, head motion, by head motion, head position, no auditory changes. Then a migraine, uncompensated unilateral vestibular loss, UVL. Longer than that, 20 minutes, 24 hours, it comes on for no reason. It can be autoimmune, it could also be migraine. Episodes that you have a sudden episode of vertigo with increased vomiting, no water changes, called maybe a neuritis. With here, also called a valvulitis, but you got to be careful for cerebellar strokes, for posterior and anterior arteries can be affected. A lot of times we will, if there's any sign of neurological stuff, we MRI or MRA. Lasting 40 hours to days, constant. Could be brain, could be vascular. There's also chronic subjective dizziness, which is something that we deal with, which is anxiety related, maybe a form of migraine. Symptoms are constant, head movement, and H must be head position. No change, so psychogenic dizziness, something non-vestibular. To our evaluations, I usually try to set aside 75 minutes for an evaluation. These are complicated patients, often very anxious, especially if had this for years and years. A few years ago, the statistics were that a vestibular patient gets to a vestibular therapist, a dizzy patient gets to a vestibular therapist after about 7 visits, different physicians. And so it can be a while. So I got more stuff on evaluation. We do something with computerized dynamic posturography. We have a thing called the Balance Master. We also do a shorter balance test, which is the clinical sensory test of, the modified clinical test of sensory integration and balance. We control test, which is a central test. And we have nice infrared video goggles that we like that we can record. That's our copy, photo of the balance mass with somebody we can use this for testing or for treatment. So the pterography, there's 6 different conditions. It assesses how well the brain is integrating visual, vestibular, and somatosensory feedback, basically. This sort of gravity information on the patient. It gives us a lot of tools that we can use to help design a reprogram. That's balance. That's the balance gym. That's one of our audiologists. Still here? Okay. Okay. And we have this harness system. There's a ceiling, and I didn't get in that the other day, so I could take a picture. But we have all kinds of things. Step over. We do jumping jacks. We do a lot of balance recovery strategies. I have people lean back in my hands, and make them take steps backwards, laterally, and so we work on reflexes, and it can do safely with the harness system on. So, a vestibular evaluation for me, if I have somebody comes in and they're young and healthy, and it sounds like BPPV, the minute I'll get a good history, I'll always do a dizziness handicap inventory. You're familiar with that at all, the DHI? It's a 25 question. The answers are yes, no, or sometimes. It gives you a score. The lower the score, the less impact the patient's symptoms are having on their ability to function with normal life. The higher the score, the worse. I always do cervical range of motion. I always do Sharp's Purser testing, which is testing the integrity of the axis, the odontoid, the odontoid process, vertebral artery testing, alar ligament testing. They're quick, and we're going to be doing Hall pikes on somebody, so we're going to be putting them in a position where we may occlude the vertebral artery. And even though there's no validity in vertebral artery testing, it's in the literature, so we have to do it and note that we have to do it. Check for cerebellar testing, the rapid alternating movements of the hands and feet. Romberg's, tandem Romberg's, oculomotor testing to rule out any central stuff. Then we do head impulse testing, which is one way of testing if there's any vestibular hypofunction on one side. And then we do BPPV testing. Well, picture of it coming up. So fast, let me go right to that. So there it is. So you have the patient sitting in front of them. I have them look at my nose. I'll oscillate their head, and I'll jerk their head quickly to one side. I'll tell them before that. And I've checked their range of motion. And the other side, so on this slide here, this is, again, she's looking directly at my nose. Jerked her head to the left. We call the head thrust test. Her eyes are looking on my nose. But down in here, she's looking straight ahead. I jerk to the left, and she's lost my nose. She's looking straight ahead. Then they'll do a saccadic direction to bring their eyes to my nose. So if it would have been a positive left head test, which would have meant that she probably got a unilateral vestibular hypofunction on the left, likely often to do a viral neuritis. Let me go in. So that, I often, not on the first visit, but often the first visit, and I'll do dynamic gait index and the functional gait assessment. Those are two assessments that give us a risk of fall on a patient. Any of this stuff, I always do tandem gait. We do 4-meter walk test to anybody. If you do 1.2 meters per second is considered to be normal. Lower the higher the risk of falling. A burst test I'll do if somebody's a little bit older, but with more impaired mobility, if they're wheelchair bound or they're walking with a cane or a walker. There's another test that we sometimes do is the Tonetti, which is another. Both the Berg balance scale and the Tonetti give us indications for risk of falling. It's just usually as a pre-test, so if we're doing therapy, we can go back and do it later and retest and see how much better they're doing. And this is just, I did this because you guys were here. This is a head shaking nystagmus test. A lot of videos on my flash drive here. I'm standing in front of the patient, shaking that. She's wearing the video goggles. Vision denied. She's in the dark. He's in the dark. Look at, so that's a positive head nystagmus test. So it's beating. You gain the nystagmus relationship to the patient, and the fast beat is beating to the patient's left. So that indicate a right unilateral vestibular hypofunction if it's beating to the left. Next slide. Vestibular reflex testing, we just talked about the head thrust test. That's looking at the vestibular ocular reflex, how well it's working. And dynamic visual acuity testing is another test we do where the patient is sitting feet away or 20 feet away from a Snellen eye chart, which has got 5 letters that decrease in size, and see what the static visual acuity is. And we should head with a metronome and have the eye chart again and see if there's a difference. A 2-line difference is considered to be normal. So the bedside test, that if those are positive, there's most likely the patient's had a vestibular hypofunction. Head impulse test again. This is part of my history. We just kind of went through that. I know you guys got to go. Constant med, change in the hearing, so all that stuff we just went through. This is a red flag, so these are what would cause me to make a referral to either neurology, have them see one of the doctors, or primary care, whoever referred them to us, and we just get imaging or something done. So definitely isolated hyperacute, really over-the-top vertigo, which assists and doesn't follow the rules for benign positional vertigo or Meniere's disease. acute vertigo with intact head thrust test. So if somebody doesn't have a viral neuritis, they need imaging. Vertigo with a new onset of headache, occipital headaches. You can always go temporal arteritis and different like that. Any central signs. So I always do ocular motor testing and cerebellar testing. And acute hearing loss, vertigo with hearing loss, we want to make sure they get in for looking for acoustic neuromas and things like that. So dysarthria, double vision, dysphagia, drop attacks, loss of consciousness, and positive vertebral artery testing. Somebody has a positive vertebral artery test, need to see somebody before we do anything else. So I'd stop my evaluation if I find a positive vertebral artery test. Modified version. Picked up 2 of those, and I did pick up a odontoid fracture on one of my patients who had a fall. It was just about 3 months ago. Exertion, working about cardiac stuff, able to stand without assistance. Lateral repulsion, they stand up and they just go off to the side. Headaches, and decrease in muscle strength is non-dermatological. So anyway. So in 2009, we did a big outcome study where we sent surveys to 800 patients that we had not seen since 2001. Of the 800, so they ran, but that was probably most of our patients. We had 72 who actually responded, and we up with phone calls. We kept people with list. 72% of the respondents were female, and 28% of the respondents are male. The statistics, male and female, are more. They're probably more like 60-40 that we see in our clinic. Average of treatments was 6.2 weeks. Average number of visits was 3.3 weeks. And we sent them a questionnaire, and we asked, did the treatment help? Was 0, it didn't help at all, and it was very helpful. 8.7 on that 0 to 10 scale, 8.07 showed that it helped with a standard deviation of 0.55. 74 treatments at age group on the 10 scale, this time with 0 being no symptoms and 10 being the worst symptoms, was 7.27. After treatment on a 0 to 10 scale was 2.44, so significantly. The dizziness handicap inventory, HI, is that the highest score you can get is 100, was a 0. Average treatment DHI for those people were 33.1. Sedation was 13.9. After treatment was 13.58. So the lower the score, the less their symptoms. So that's considered to be pretty good. We're another one. We actually started one a couple of years ago, but we had personnel changes and the ball got dropped. So we're gearing up for another big thing. A lot of paperwork, a lot of spreadsheet and gathering data. So just for this thing, when Dr. Klayman asked me to, is Dr. Klayman here? Hi. Excuse me. When she asked me to do this, I sat down and went through our patients for November. So at the end of November, we had 54 dizzy patients. So patients, we saw them, we gave them fault points, meaning we gave them fault appointment, or had perfect normal testing and were asymptomatic. We saw them and we didn't treat. 28, 50% were BPPV, were migraine, hypofunctions. 14 of those 28 of those 54 patients we considered to have a risk of falling based on the score on the dizziness handicap inventory. The dynamic gait index or functional gait assessment, we use criteria, and then on the performance balance master, we can get it resolved, documented. 8 of those referred to physicians, and 3 were considered to be cervicogenic. So cervicogenic is often mixed, so it'd be a vestibular problem. So in patients, this is just the kind of, so 8 were clean, posterior canal BPPV, roll table with the Epley maneuver, and they're better. We're posterior canal cupulolithiasis. Canalithiasis, you understand the difference between canalithiasis and cupulolithiasis. So canalithiasis is when the crystals are free floating in the fluid of the inner ear, and cupulolithiasis is when the crystals, the autoconia, attach to the cupula, which is the sensory organ that is stimulated when our head and fluid moves in the labyrinth. The crystals are stuck, we do different maneuvers to treat them. So dialysis was 4 in the horizontal canal, cupulocytes. The anterior canal is one of my favorite canals because it's really difficult to treat. We had 1 canalithiasis, which is actually a new maneuver we've been using for about 4 years that works. And if somebody has anterior canal cupulolithiasis, it is almost possible. Anatomically, it just can't be fixed. Now BPPV, we had 3 patients that came in that month with, this is myself and Kate, the therapist with me. Happy to answer any questions about anterior canal or anything else. So thank you for all your referrals. If you want the patient to see a physician, just specify. We'll make sure they get to see a physician and the PT. Basically, I did here. Well, it was just about urgent referrals. So we do get phone calls, and or come in and they're looking for they want something that within a day or two. I think it was right before that. But it does. That's fine. That's fine because it's just slide does what somebody just said. So it's an urgent patient is someone who can't work, can't drive, had multiple falls. We try to get those patients in. We just now, for the past couple of months, we've been reserving a spot. So there is 1 urgent dizzy spot every week that we don't fill until Thursday afternoon. One-on-one, Kate and I alternate every week that Thursday afternoon dizzy urgency. If it's not filled by Tuesday afternoon with a patient or somebody who's calling in trying to get in, but if you have an urgent patient, just let us know and we'll try to get them in. We are bringing out just to see a PT. It's probably 3 to 4 weeks to see a physician. It's going to be 6 weeks anyway. Slots. And thank you. This is a little bit boring, but anybody have any questions?
Patients who do not have vertigo but just have general kind of balance issues as well. We'll do a balance evaluation if we have concerns.
Definitely. So they're just for the blue out there, asking if we see patients with balance that don't have any real vertigo or other things. But most of the patients we get, people come in with referral for dizziness. And evaluation, we do the full evaluation. So we measure it. There's age-related stuff that happen. There's peripheral neuropathies that can cause people to be off balance. And, we do treat those. They can be a little bit more difficult. We see a lot of post-concussion syndrome. So all those things. Our falling patients all go in the solo step. We have them come in a couple times a week and work. That's the harness system. Thank you.